Hi, my name's Omar Sain. I'm a core surgical trainee. Today we're going to talk about urinary tract stones. Here goes. So, kidney stones are later, unless of course you're referring to stones within the kidney itself. More precisely, it would be nephro or urolithiasis. Renal colic is the typical colicky pain that patients get when a stone is passing down the peristaltic ureter. It's the most common cause of an acute admission in urology. You have to know about it. Peak presentation is in the 20s to 50s, and around 1 in 10 of us will get them by the age of 70. The most common precipitants are dehydration. There's 3 points of narrowing within the ureters: the pelviureteric junction, where the renal pelvis collates into the ureters, the mid-ureter, where the ureter crosses the pelvic brim, and then the 2 vesicoureteric junctions, where the ureters open into the bladder, vesico referring to the bladder. These are the points where stones most likely become impacted. Kidney stones may be pain, hematuria, or UTIs. They may be asymptomatic and found incidentally. Ureteric stones present with loin to groin pain, especially when the stone moves to the lower ureter. Bladder stones may cause bladder symptoms such as frequency or urgency. Looking at the pathophysiology, about 3/4 of stones are calcium oxalate stones. Struvite stones account for about 15%, typically known as infection stones, and include the typical staghorn calculus. Uric acid stones are radiolucent and account for around 5%. The causes are always a genetic predisposition and an environmental trigger. Commonly, idiopathic hypercalciuria is found. Hyperparathyroidism raises the serum calcium, as does sarcoidosis. Familial causes include cystinuria, infection, urease-producing bacteria split urea into ammonium and carbon dioxide. This alkalinizes urine. Impaired drainage causes stagnation of urine. You're more likely to get renal tract stones if you're male, have a family or personal history of renal tract stones, are in your 20s to 50s, and are Asian or Caucasian. Clinically, these patients with ureteric stones present acutely to A&E. They have sudden onset, intermittent, sharp, colicky pain. It's typically loin to groin. They're in severe pain, typically clutching the side of their abdomen. They may have nausea, vomiting, and are typically restless. This is usually due to the pain. Fevers are a warning sign. On examination, you may find loin or renal angle tenderness. Criteria for admission typically include evidence of infection, impaired renal function. These together would suggest an infected, obstructed system, which is a surgical emergency, intractable pain, and then those such as the elderly, pregnant, pediatric, or immunocompromised. There's a differential diagnosis and always rule out the life-threatening causes: AAA, ectopic pregnancy, perforated viscus, and then ischemic bowel. Depending on where the pain is, there are other differentials. Remember testicular torsion in all male children presenting with abdominal pain. Investigations should include bedside, especially looking for a SIRS response or evidence of infection with fevers, a urine dipstick looking for hematuria or other signs of infection, infective markers such as the white cell count and CRP, renal function for urea, creatinine, and EGFR. Remember, the infected, obstructed system is a surgical emergency. The current gold standard is a CT kidney ureter bladder. This is unenhanced, hence there's no contrast used, and this may be especially important in patients with a reduced EGFR. On X-ray, around 90% of stones are radio-opaque. Ultrasounds typically look for hydronephrosis, which is enlargement of the kidney or ureter in response to an obstructing stone. This axial CT shows a left vesicoureteric stone. The following CT shows a left pelviureteric junction stone with hydronephrosis. Treatment may be non-operative for uncomplicated stones. Those less or equal to 1/2 centimeter in diameter are typically going to pass within the next 4 to 6 weeks. Those up to 10 millimeters have a 50% chance of passing. Patients should stay well hydrated, and alpha-1 blockers may be used. Acute or complicated stones should first prioritize stabilization and management of sepsis. A ureteric stent or JJ stent should be passed endoscopically to allow bypassage of urine into the bladder, or a nephrostomy, which is a percutaneous tube directly into the renal pelvis. Electively, there are multiple types of surgery involved. extracorporeal shockwave lithotripsy to fragment the stones, ureteroscopy, which is an endoscopic procedure with laser fragmentation, percutaneous or through the skin nephrolithotomy to open up a tract to remove stones, or open surgery for more complex stones or those for which the above have failed. Increased fluid intake is key to prevention. In summary, suspected urinary tract stones. Look for the warning signs: infection, obstruction, intractable pain. Organise an urgent CT kidney ureter bladder and consider urgent or emergency intervention. Otherwise, patients' pain can be managed and they can be seen the following day for a CT-KUB. You may opt for non-operative management or use a variety of what's available. Thank you for listening. If you liked what we did, subscribe.